Okay, let's continue with part 3. So we will talk about quetiapine and loricidone. Quetiapine is an atypical antipsychotic, and it's commonly used in the treatment of both manic and depressive episodes in bipolar disorder. It is also used as an adjunct. We use it off-label for insomnia. It works primarily as an antagonist at serotonin and dopamine receptors, which contributes to its mood stabilizing properties. Clinical studies have demonstrated that quetiapine is effective in treating acute depressive episodes in bipolar disorder. The FDA has approved quetiapine for both the treatment of acute mania and bipolar depression. So this is typically initiated at a low dose, usually around 50 milligrams at bedtime. I tend to err on the lower side and would start at 25, sometimes even 12.5. It's a very teeny tiny pill, but I like the patient to get used to it before, they have all these side effects and don't take it. It's titrated based on the patient's clinical response and tolerability. The recommended dose for bipolar depression ranges from 300 milligrams to 600 milligrams a day. So sometimes I have to sell this to the patients when I'm starting it off at a low dose. They're very scared of quetiapine, an antipsychotic. So I usually tell them, I'm starting you off on a very teeny tiny dose. Doses go as high as 600 milligrams, and they're like, oh, okay then. And they're okay to take it. Some of the common side effects are sedation. So it's very good if they're having insomnia. Weight gain, of course, is not great. Dry mouth, dizziness, some metabolic changes such as increased blood sugar and cholesterol levels. Definitely you have to monitor the patients for these side effects regularly. Due to this sedative properties, it can be beneficial for the patients who do experience insomnia during their depressive episodes. However, caution should be exercised in patients with a history of metabolic syndrome or cardiovascular issues. Now, loricidone is another atypical antipsychotic that has gained attention for its use in treating bipolar depression due to its unique receptor profile and favorable side effect profile compared to other antipsychotics. It's shown to be effective for treating major depressive disorder episodes associated with bipolar 1 disorder because there's no activation to mania. The typical starting dose for this is about 20 milligrams. You have to make sure that they're taking this with at least a 350 calorie meal. So make sure you educate the patient on that. And this can go anywhere from 20 milligrams to 120 milligrams a day based on how the patient responds and their tolerability. Now, some of those side effects, as you'll see, sedation, weight gain, dizziness, the increased blood sugar and cholesterol. Loricidone's side effects, they have less sedation with loricidone, but of course, because you're telling them to take this with a 350 calorie meal, sometimes their appetite is off. So I normally tell them to take this medication in the evening. It can still cause akathisia, nausea, somnolence, and even extrapyramidal symptoms. So it can cause EPS. It does have a lower risk of weight gain compared to many of the other atypical antipsychotics, but that is normal. I had a patient that was taking this medication, tolerating it very well, but she gained 60 pounds, and so we ended up having to change her medication because she was not going to continue to take it and gain weight. The considerations for loricidone, of course, requiring the food intake, so that can influence their adherence. So educate the patients about that when you're prescribing it. Make sure you tell them that they have to take loricidone with a 350 calorie meal. It may be preferable for patients concerned about weight gain or metabolic issues because the majority of the patients do not gain weight. However, you may have one that might. So when you want to consider quetiapine and loricidone, so sedation versus non-sedation. So it just depends. Is your patient having insomnia or are they not? Of course, quetiapine is more sedating than loricidone is. Patients' preference also regarding daytime alertness may be something that you have to consider. So if you have a patient that is disabled, not working, they might want to sleep all day. Quetiapine's okay because they might be drowsy, especially if you get up to one of those large doses. The weight gain risk, of course, quetiapine carries the higher risk of weight gain when it's compared to loricidone. And you have to discuss that with the patient. Remember, informed consent. Both medications work relatively quick, so it doesn't have that long lag time before it takes effectiveness. It works relatively quick for alleviating depressive symptoms. But of course, nothing is cookie cutter, so individual responses may vary. Long-term management should be to consider the metabolic effects associated with these medications. So you definitely have to monitor them for their blood sugar, their cholesterol, their BMI. So, what are some of the non-pharmacologic interventions? Behavioral therapy, which focuses on increasing pleasurable activities and events and providing the skills necessary to obtain more reinforcement. There's cognitive therapy that teaches patients to identify, challenge, and modify their negative thought processes. They have the dialectical behavior therapy, cognitive behavioral therapy. That is the most common form of psychosocial intervention, and that combines behavioral and cognitive therapies. And you have interpersonal therapy. The focus is on depressive symptoms and the social context in which they occur. And although medication treatment of bipolar is vital, adequate preparation for treatment is more likely to ensure its success. So, 6 psychosocial interventions are very important and supported early onset bipolar spectrum disorder. So, child and family focused cognitive behavioral therapy, multifamily or individual family therapy, psychoeducation, family focused treatment for adolescents, dialectical behavior therapy for adolescents, interpersonal and social rhythm therapy for adolescents, and cognitive behavioral therapy for bipolar disorders. Additionally, providing psychoeducation to the patient and family members about the disorder is critical to successful treatment. So you want to make sure that they understand. You have to address the patient's educational functioning. You want to reach out and get the teacher rating scales in because the teacher is with them most of the day, most of the time, right? Except during the summers. You may do some kind of psychoeducational testing. The teacher would be great for classroom observation. Development of an IEP or a 504 plan supplements other interventions and provides for more comprehensive treatment. And there's a greater likelihood of success for this child or adolescent. Patient education. So understanding bipolar disorder is very, very important for the patient to have a clear understanding of what bipolar disorder is, including its symptoms. For bipolar 1, bipolar 2, and cyclothmic disorder. And the nature of mood episodes like manic, hypomanic, you want them to understand what that is, and the depressive episodes. They should be educated about how these mood changes can affect their daily lives, their relationships, and their overall functioning. This foundational knowledge helps demystify the condition and reduces the stigma. So, recognizing symptoms, patients should learn to identify early warning signs of mood episodes. That includes recognizing shifts in energy level, sleep levels, sleep patterns, irritability, or changes in thought processes. So I usually like to tell my patients, like, I'm giving you a medication to feel better. And I want you to feel good. I don't want you to be depressed, but I don't want you to get in any legal trouble or get into any trouble either. So that, mania that they enjoy, some patients enjoy that and they want to feel that, can lead them to trouble. So usually education helps them to understand, although you might be enjoying being manic, that is not a good place to be. So early recognition can facilitate timely intervention and help prevent full-blown episodes. The importance of treatment adherence education, also adhering to the prescribed treatment plans is vital. Patients should understand that bipolar disorder is a chronic condition and it requires ongoing management. A lot of patients, they'll take the medicine and then, especially in that super, super depressed stage, because they don't want to be like that and they want to feel better. And then as soon as they feel better, they want to get off the medication because they don't need it because now they feel better. So you have to educate them on the importance of treatment adherence. So that includes taking their medications as prescribed, the mood stabilizers or antipsychotics, and attending regular therapy sessions. Discussing potential side effects of the medications can also prepare patients for what to expect and encourage adherence. Teach them about coping strategies for managing their symptoms effectively. They should be educated on techniques such as mindfulness practices, stress management skills, and healthy lifestyle choices like regular exercise and balanced lifestyles, balanced diet, what we teach all of our patients. These strategies can help stabilize mood and improve overall well-being. Support systems. Oh, did I? Okay, I'm going to leave it right there. Support systems. Did I lose I'm sorry, I lost my complete train of thought right there. Okay. I don't know what I just did with oh, it went backwards, y'all. I'm so sorry. I have to go backwards. Let's see. Oh, I went backwards on mine, but not on yours. Okay, there we go. Sorry about that. It skipped and I kind of lost my train of thought. So we went over the coping strategies. Okay, so support systems encourage patients to build a strong support network That can include family members, friends, support groups, or mental health professionals who understand bipolar disorder. Educating patients about how to communicate their needs effectively with their support systems can enhance their coping mechanisms. And of course, crisis management planning. So, patients should work with you to develop a crisis management plan that outlines steps to take during severe mood episodes or emergencies. And you want to document that there is a crisis management plan in place. This plan can include an emergency contact, preferred hospitals or clinics for urgent care, specific actions that their loved ones can take if they experience a manic or depressive episodes. Um, I remember taking care of a young girl. I don't know, she might have been in her 20s, but her mother was so resistant to the diagnosis for her daughter. Her daughter clearly had bipolar 1, not bipolar 2, bipolar 1. And she had experienced a full blown manic episode. Mother did not by any means want to accept that diagnosis, and she convinced the patient that she should not be taking any type of antipsychotics, that maybe the mental health professionals were the ones who needed the medication, not her. And the only medication she would allow her to take was escitalopram. This was documented and signed. Lots of teaching. Why? Because if something happens to this patient and you have not clearly documented the patient's refusal, the patient had the mother with her, the mother's refusal, no medications, only taking escitalopram. So probably a couple of months later, this young girl, and she wasn't that young, I think almost drove her car into a river, like something really off the wall when she was manic. She had become manic again. So she had been doing all these things. And then the mother called in a frenzy because the daughter was manic and wanted her medicated. Of course, this patient had to go to the hospital first. She was hospitalized, and when she came out, she was on an antipsychotic. I don't quite remember the medication. It was a provider I was working with. However, there's clear-cut cases where patients will not adhere even when you're educating them. So, but there was a crisis management plan in place so that mother did know to call and alert the staff that the patient was in a crisis and was in mania. Okay, so lifestyle modifications, you want to educate patients about the importance of lifestyle choices on mood stability. That includes maintaining a consistent sleep schedule, that sleep hygiene that we teach patients about, avoiding drugs and alcohol, which can exacerbate their symptoms. A lot of times they'll ask you, can I drink while I'm on this medication? No, no, no. Engaging in regular physical activity, especially because of the weight gain, and practicing good nutrition. Regular monitoring of the patients. They should be informed about the importance of regular follow-up appointments with their psychiatric providers, because you have to monitor the condition, right? So continuous assessment allows for adjustments in treatment plans based on symptom changes or side effects experienced from the medication. Tell your patients, don't just stop the medication. Please contact the office. Please come in. We will discuss your treatment plan. Forming that therapeutic alliance, you guys remember that, is very important. So your patient will call and come back, not just stop taking their medication. Psychoeducation for families, involving the family members in education sessions, that can enhance understanding and support within the household. Um, so many times I hear from my younger patients that their parents don't believe in their diagnosis, although one of the parents may have bipolar, or they don't want their parents to know. I have a new patient who is bipolar 2. Both of her parents are bipolar 2. She's on her parents' insurance, but she does not want her parents to know that she's taking medication for bipolar 2. But family members should learn about bipolar disorder's nature so they can provide the appropriate support during difficult times, while also taking care of their own mental health needs. Okay, that is it on bipolar. And we will quickly go over schizophrenia spectrum disorder. So some of this you've had in 591. So we'll try not to duplicate stuff that you've already had. Schizophrenia is a complex and chronic mental health disorder characterized by a range of cognitive, behavioral, and emotional dysfunctions. It affects approximately 1% of the population. It typically manifests in late adolescence or early adulthood. So we are going to talk about schizophrenia, the etiology, symptomology, diagnostic criteria, assessment techniques, and treatment modalities. So some of the key features that define psychotic disorders would be delusions, hallucinations, disorganized thinking, negative symptoms, and grossly disorganized or abnormal motor behavior. So it's characterized by the positive symptoms, which the positive symptoms are hallucinations, delusions, and the negative symptoms being apathy or lack of emotion. Cognitive symptoms are the impaired memory and attention. Positive symptoms involve the presence of abnormal experiences or behaviors, like there's different hallucinations, sensory experiences without external stimuli, like hearing voices. A substantial number of children and adolescents report psychotic-like phenomena. These symptoms reports are qualitatively different than true psychotic symptoms, and most youth reporting these experiences do not have a psychotic illness and will never go on to develop a psychotic illness. Reports of psychotic-like symptoms may simply represent misunderstanding the question or developmental expressions of normal psychic phenomenon, especially like in younger children. Reports of psychotic-like experiences may also be predictive of other types of psychiatric problems like anxiety, trauma, substance abuse. So what are delusions? Delusions are strongly held false beliefs that are resistant to reason, like paranoia. So you just cannot talk them out of that. And according to the DSM-5 criteria for schizophrenia, diagnosis requires at least 2 of the following symptoms present for a significant portion of 1 month: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms. And additionally, there must be evidence that these disturbances cause significant impairment in social or occupational functioning. The etiology of schizophrenia is multifactorial. It involves genetic, neurobiological, environmental, psychosocial factors. And research pretty much indicates that individuals with a family history of schizophrenia are at a higher risk of developing the disorder. Neurobiological theories suggest that dysregulation of neurotransmitters such as dopamine and glutamate play a significant role in the pathophysiology of schizophrenia. The dopamine hypothesis has long been central to the understanding of schizophrenia's neurobiology. This hypothesis says that hyperactivity of dopaminergic pathways, particularly in the mesolimbic system, contributes to positive symptoms such as the hallucinations and delusions. Conversely, hypoactivity in the mesocortical pathway is thought to be linked to negative symptoms like apathy or social withdrawal. So, dopamine, you'll think of the hallucinations and delusions, whereas glutamate, some of the symptoms of schizophrenia, is related to glutamate, apathy and social withdrawal to the mesocortical pathway. Glutamate, that hypothesis suggests that the hypofunction of NMDA receptors may lead to symptoms of schizophrenia. Reduced glutaminergic activity can disrupt synaptic plasticity and contribute to cognitive defects. In serotonin, alterations in serotonin signals may also play a role in schizophrenia. Atypical antipsychotics often target serotonin receptors alongside dopamine receptors, and that is indicating the importance of symptom management and knowing and understanding how you're treating which neurotransmitter. Some environmental factors that you need to consider is prenatal exposure to infections, malnutrition, psychosocial stressors during like critical development periods, and substance abuse can also contribute to the onset of symptoms. So I was listening to a friend of mine talking about one of her relatives, and truly they thought he was schizophrenic because I think it was cannabis he had been using for a long time. So he presented as someone with schizophrenia. And I do believe once he was no longer using cannabis, he no longer had those symptoms. So the brain in schizophrenia. Structural brain abnormalities, neuroimaging studies have revealed various structural abnormalities in individuals with schizophrenia. So, enlarged ventricles has been reported that they have enlarged lateral and third ventricles, suggesting loss of surrounding brain tissue. Reduced gray matter volume in regions such as the prefrontal cortex and temporal lobes, which are, of course, critical for cognitive function and emotional regulation. Abnormalities in the hippocampus are often found to be smaller in individuals with schizophrenia, which might relate to the memory defects that's observed. Functional brain imaging techniques like the MRI have shown altered brain activity patterns during cognitive tests among individuals with schizophrenia. Then there's reduced activity in the prefrontal cortex during tasks requiring executive function. That's been consistently observed. And studies indicate disrupted connectivity between different brain regions, like between the frontal areas and the limbic structures. and that may be contributing to disorganized thoughts and behaviors. Inflammation, there's some research that highlights the role of neuroinflammation and neurodevelopmental factors also in schizophrenia. Elevated levels of inflammatory markers have been found in some patients with schizophrenia, suggesting that an immune response may contribute to symptomology. Prenatal exposure to infections or stressors can disrupt normal brain development processes, potentially increasing vulnerability later in life. So, what is the absence of normal behaviors found in healthy people? That's the negative symptoms. Loss of interest in everyday activities. They tend to lack emotion. There's a reduced ability to plan or carry out activities when they're having these negative symptoms. They don't take care of themselves, so they neglect their personal hygiene. They may have social withdrawal, really low motivation, and their affect is flat. So they have a reduced emotional expression. And of course, they have the anhedonia, which is the inability to experience pleasure. So those are the negative symptoms. An increase in presence of abnormal behavior, well, that's the positive symptoms. And positive symptoms include hallucinations, delusions, thought disorders, movement disorders, some cognitive symptoms of psychosis. They may have problems with thought processes that can interfere with the ability to perform just routine daily tasks. They have problems making sense of information. They have difficulty paying attention. They have memory problems, very disorganized thoughts, and impaired communication. Those are the positive symptoms. So let's talk about different delusions. They're diagnosed by the theme of the delusion being experienced. So the erotomanic, those delusions, it's belief that a person usually has a higher social standing. They believe that maybe some famous person is in love with them because they are all, all of this. And they really truly believe that. They may have grandiose delusions. That's the belief that they have this extraordinary talent, fame, or wealth, or power, despite there's no, evidence for it. Like they may profess that they're a prophet and they know all these things, or they're like this kingpin in the mafia when they're not. They may be jealous. They may have jealous delusions. They may have persecutory delusions. And that's the belief that they're being spied on, drugged, followed, slandered, cheated on, somehow mistreated. Like maybe somebody's trying to poison them. If you've ever seen A Beautiful Mind, I do believe he had persecutory delusions. Um, the jealous delusions, belief that their partner is being unfaithful. They have no proof of this. There is nothing the partner is not, but they are adamant that their partner is unfaithful. They may have somatic delusions, and that's the belief that they're experiencing some physical symptoms, some kind of bodily dysfunction, or they're suffering from some medical condition. Like they may say there's bugs crawling under their skin, which is not so. They may have mixed or unspecified delusions. If there's no single theme that dominates, the delusions are considered mixed or unspecified. So the DSM-5 criteria, two or more of the following present for a significant portion of time during a 1 month or less if successfully treated. At least one of these has to be delusions, hallucinations, disorganized speech. For a significant portion of the time, level of function in one or more areas like work, relationships, self-care is markedly below level achieved prior to onset. Continuous signs of the disturbance persist for at least 6 months. The 6 months period must include at least 1 month of symptoms that meet the criteria above, like the active phase symptoms, and may include periods of prodromal or residual symptoms. During these prodromal or residual periods, the signs of disturbance may be manifested by only negative symptoms or 2 or more symptoms that were listed in criteria 8. Schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out because there's no major depressive or manic episodes during the active phase, or if mood episodes occur during the active phase, they've been present for a minority of total duration of active residual periods. The disturbance is not attributable to the physiologic effects of a substance or another medical condition. If there is a history of autism spectrum disorder or communication disorder in childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are present for at least a month. So we'll go on to treatment. So treatment includes pharmacologic, which is first generation, the antipsychotics, which are the typical antipsychotics. Those medications have been around since like the 50s. And those typical antipsychotics work by blocking dopamine receptors in the brain. And while they can be effective in reducing positive symptoms of schizophrenia, such as like the hallucinations or delusions, they're often associated with a higher risk of extrapyramidal side effects. The tremors, rigidity, tardive dyskinesia. Some of the more common typical antipsychotics are like haloperidol, which is Haldol, and that's often used for acute psychosis. So you'll see that more in an inpatient setting. It's effective, but it may cause EPS. I have had a patient, no, she was not on haloperidol. I apologize. That was in the hospital. Um, Thorazine or chlorpromazine, that's one of the first antipsychotics used for various psychotic disorders, but it has sedative effects. There's Prolixin, it's available in long-acting injectable forms for maintenance therapy because a lot of patients with schizophrenia need the long-acting injectables because they come off of their medications quite often. Now, the atypical antipsychotics, that's the second generation, they've been around since like the 90s. They tend to have a broader mechanism of action that includes the serotonin receptor antagonism alongside a dopamine receptor blockade. They generally have a lower incidence of EPS compared to the typical antipsychotics, but they may carry risk for metabolic syndrome like weight gain and diabetes. Some of the common atypical psychotics, risperidone, which is effective for both positive and negative symptoms. It's available in oral and long-acting injectable forms. Risperidone, aripiprazole, aricidone, olanzapine, and quetiapine are currently FDA approved for the treatment of schizophrenia in adolescents ages 13 years and older. Haloperidol is approved for the treatment of schizophrenia in adolescents ages 12 years and older. Olanzapine, which is also Zyprexa, is known for its efficacy but associated with significant weight gain. We talked about quetiapine. That one, remember I told you guys it was used off-label for sleep disorders. It has sedative properties. Aripiprazole, I like aripiprazole. It's a partial agonist of dopamine receptors. It may have a lower incidence of weight gain. Laricidone, Latuda, is approved for treating schizophrenia with a favorable side effect profile regarding weight gain. And then there's adjunct medications. So long-term compliance is rare in children and adolescents. And can you imagine a child or an adolescent having to start off with a chronic condition and having to take medication from an early age? Very, very hard for them to adhere to a treatment plan. But they should be continued on their initial medication treatment for 52 weeks. Yes, so again, long-term compliance in children and adolescents is rare, and only 10% will take their medication for up to those 52 weeks. They need to be on it for at least 52 weeks. It's chronic, so they're always going to be on this medication. In some cases, adjunctive medications can be prescribed to address symptoms or side effects associated with their antipsychotic treatment. Antidepressants can be used if depressive symptoms are present alongside schizophrenia. Mood stabilizers like lithium valproate, which we talked about before, they can help manage mood swings or agitation. Benzodiazepines, I know you guys hate to hear that word. I hate to use that word. It's almost like a bad word. However, we do have to use benzodiazepines sometimes. And sometimes they're prescribed for short term for anxiety and agitation. Long-term management of schizophrenia often requires ongoing medication adherence to prevent relapse. Patients should be monitored regularly for side effects, particularly metabolic changes associated with atypical antipsychotics. Psychoeducation about the illness and medication adherence strategies, they're very essential components of comprehensive care. Some of the non-pharmacologic treatment would be psychotherapy, social skills training, which is SST, cognitive behavioral therapy, family therapy, and support groups. Cognitive behavioral therapy is one of the most researched forms of therapy for individuals with schizophrenia. It focuses on helping patients identify and challenge distorted thoughts and beliefs related to their experiences. CBT can assist individuals in developing coping skills for managing their symptoms, reducing distress from hallucinations or delusions, and improve their overall functioning. Supportive therapy provides emotional support while helping patients navigate daily challenges associated with schizophrenia. Supportive therapy emphasizes building a trusting relationship between the provider and the patient and allows individuals to express their feelings without judgment. Family therapy, of course, family involvement is very important in treating schizophrenia because the family dynamics can significantly impact an individual's recovery process. Family therapy aims to educate family members about the disorder, improve communication within the family unit, and reduce stressors at home. A lot of family with schizophrenic family members are very, very stressed. It's a very difficult diagnosis. It's very difficult on not only the patient, but the family. So we want to foster a supportive environment because that's conducive to the patient's treatment. Social skills training focuses on enhancing interpersonal skills that may be impaired due to schizophrenia. Social skills training helps individuals practice social interactions in structured settings, helping them to improve their ability to communicate effectively, build relationships, and function better in community settings. Okay, almost done. Patient education. Understanding schizophrenia, educating patients about the nature of schizophrenia is fundamental. Patients should be informed that schizophrenia is a brain disorder that can affect anyone and is not caused by a personal weakness or any character flaws that they have. Understanding that it's a medical condition can help reduce the stigma and promote acceptance of treatment. Patients should be educated about the various symptoms of schizophrenia, like the hallucinations, seeing or hearing things that aren't there, the false beliefs or delusions and thought disorder, the lack of motivation, the social withdrawal, reduced emotional expression, difficulty in experiencing pleasure, impaired memory and attention deficits, difficulties with executive functioning. Recognizing these symptoms can empower your patients to seek help early when they notice changes in their mental state. We want to educate them about treatment options. That's vital. Patients need to understand that schizophrenia is typically treated with antipsychotic medications, and we have to give them all the good, the bad, and the ugly. These medications help manage their symptoms but may have side effects, and they need to be informed about the importance of adherence to the prescribed medication regimens. They need to know about psychotherapy with CBT, supportive therapies that can help them cope with their condition. Involve psychoeducation, which involves educating the patient and the family about the illness and foster understanding and support. Patients need to be aware of the importance of regular follow-ups, which sometimes ACT teams have to go out and find them to do follow-ups. Because you want to monitor the treatment efficacy and adjust medications as needed, right? Teach them coping strategies that can help them enhance their ability to manage their condition. So some stress management techniques, mindfulness, relaxation exercises, physical activity that can help reduce stress levels. We talked about social skills training. We talked about interpersonal therapy that can help them with their communication. Encouraging patients to maintain a daily routine to provide structure and stability. Encourage them to have a good support system. Family support, which of course we talked about educating their family members, recognizing the warning signs indicating an impending relapse or worsening of symptoms. We want to make sure they understand what that is. Early recognition allows for timely intervention, which may prevent them from having to go in the hospital or deteriorating even further. Healthy lifestyle choices, like promoting good diet, good well-being, exercise. They want to have a nutritionally balanced diet. Regular physical exercise that has been shown to improve mood and reduce anxiety. We all need regular physical exercise. Avoiding substance abuse, educating them on the risks associated with alcohol or drug use, because that can exacerbate their symptoms or interfere with their medications. Okay, that is the end of your bipolar schizophrenia lecture. If you have any questions, please reach out and let me know.